So I'm here with Sarah Simpson at the CPHC Conference 2016, and Sarah's been talking about the role of health system in, changing health inequities or
tackling health inequalities.
Yeah, so interested in what you've had to say this morning in your presentation about that.
Okay, so part of my discussion has been about that while the health system is only part of the equation in tackling health inequalities, because we know that health inequalities are largely created by social, both material and non-material determinants of health and environmental determinants of health. The health system has a role in terms of putting its own house in order and doing what it can do within its own system to ensure access and quality of care to all people, and that it doesn't alienate, stigmatise, marginalise people. There are a lot of barriers often in the way for people even to get to care, especially we talked this morning, one of the presenters talked about the inverse care law. And if we look at the Sydney Metropolitan Partnership around Aboriginal health, if you look across the 7 or 8 areas that they have in that document, all of them have something about primary care, because we know that there's an inverse relationship. So one thing is about actually understanding what we can do within the field where we work. And part of this came about because when I was working with WHO in the European region, they worked very much within a health systems framework. They were working with ministries of health to strengthen their health systems and broaden them out, so they had a stronger focus on primary care and developing their public health systems. But also because that's where the agency worked through ministries of health. And so it's important to actually do that business, that core business, right, and make sure that people get the health services that they need, that there are not barriers, that preventive health services, as we talk about here, are listed on the Medicare benefit schedule. People can get an exercise prescription. But it's also about designing the systems in a way that they are, as we heard this morning, people feel connected to them. They feel that they are systems that they want, not so much that systems that we design for them. So that's part of it. And then your question to me was kind of what's in a health system. So the health systems kind of framing is very much like it's a bit of an academic discussion or a theoretical discussion. It has come out of this work of health systems in transition in a lot of the former Soviet Union countries, but also in other parts of the world. So it's a way of looking at how the system works. And, as you say, it could be different bits, as we heard this morning, fragmented bits, but it's about trying to look at it as a whole and then saying what do we think it should look like and then what different bits are. And so for me, it takes the discussion beyond healthcare, because for me in a health system, you're also talking about the people in that system who do public health, but not at a clinical level. You're talking about all the health promotion and population-based efforts and a lot of the work that takes place at the community level in, say, for example, New South Wales, the health services. So even though a lot of what the people do who work in the health services at the community levels is maybe more community development rather than clinical care, but that's still part of that system. And how we work with people makes a difference, and how we come across. So that's part of one of the things we were talking about. And also because we can hardly interact with other sectors and ask them to do more, to do something, to do better with communities if we haven't got our own house in order. I always used to feel this. How can we go to Social Security and say, well, you need to do this, when we knew that people weren't using primary care services, or we weren't managing, people who have chronic conditions, that they weren't being as well managed as for lower income people as they were for higher income people, despite the intent of the system, which is universal, yes? So we have to we need to understand what's wrong and what we need to be fixing in our own system while we're intersecting with other partners. And also by doing this, it helps us see what it is that we're expecting to ask of other partners. So, is the problem actually what we think it is about education, or is it something else when we're starting to look at what's wrong in our own system? So that's part of the other reason. So you have to keep an eye on both, but people have to work in the field that they're working in. So health people are working in the health field, so they can't be saying that they're changing education as a social determinant, but they might be working to address issues around that and then advocating with other partners in the education education sector to improve how children learn by dealing with that.
And what are some of the success stories that I guess you saw in Europe yourself when you were working in Europe?
I'm loath to sort of talk about success stories. So I think that, you know, the Norwegian policy on tackling the social gradient is a success story in terms of it changed the discussion. It was one of the first countries, in fact the first country I think, to actually try and take a gradient approach. So, and because the language around remedying health disadvantage, tackling the gap or tackling the social gradient was relatively new. So I would say that was a success story in terms of it opened up that discussion. Then there are other success stories, so in the sense that, again, I talked about program Mura in Slovenia, which again, yes, Slovenia is a fairly small country population-wise, but it was a region where there was particular socioeconomic deprivation, and what they did was focus on building up the kind of economic development in the region and really trying to look at that as a way of improving people's health. So doing things like changing the college so that people could stay on for agriculture, and also for doing local development in the sense of fruit and vegetables being produced, nature walks, those sorts of things. So really made a local investment around, and that came from the kind of health promotion people, and then began to look at health inequalities. Like Slovenia then moved to looking at having a health inequalities profile developed in collaboration with the WHO and other people, beginning to look at that. So usually the success stories may start quite small because a space opens up and someone decides to look. So again, as we discussed this morning, well, we don't think there are inequalities there, but we take some data and we look and we say, oh, actually we could be doing this a bit better, or we could actually be doing something because this group appears to be missing out. And then sometimes that opens up the space for the policy conversation. So another program was in Spain, the Navarra Health Promotion Program, which started back in the late 1980s, where they started working with Roma communities using peer mediators to find out what the community's health needs were. So they would do a community needs profile, and then negotiate with the community around certain health issues that they wanted to address. Usually it was around women's and children's health, like immunisation, but also getting the kids to school so the kids would be immunised, but also because of the way it was dealt with, that the kids' school attendance started to improve. Also what happened as part of that program was, because there was a wider push from the Spanish government to improve their efforts, a few things happened. So one was that they did their first Roma kind of census and started collecting better data on the Roma. So a bit like we have with Aboriginal and Torres Strait Islander health, that we had better identification, they were able to have better comparative data. But the other thing that they started to do is that the issues that the community started to look at and were important started to change. So then they began to tackle other determinants of health, like some of the health behaviours, because non-communicable diseases were taking on greater importance. So yeah, that was another one. In Romania, for example, you've got TB. They had within a small area, they wanted to improve testing and compliance with treatment for TB. And so again, they used a similar Roma peer mediated program, which eventually got taken up into the Ministry of Health as part of their wider kind of peer mediated program. So they're kind of success, the success stories. Often it starts with something that's small, or something where they do things, they start to put things into a system process, so it becomes a wider part of how people should be doing business.
And what are the things that are standing in the way, I guess, of this kind of change movement? Like, what are some of the barriers?
I think some of the things that I'm hearing discussed as well in the Australian media. So I think that, and we've seen a bit, I think, with the Brexit as well, is that kind of the way the system does or doesn't work at the moment. People who are being left unemployed, who previously, we've got a middle class that's disappearing. You're seeing an emerging precariat in a lot of countries, not just here, but in countries in Europe. So people are feeling disenfranchised and marginalised and not listened to. And so if you start talking about vulnerable groups like refugees or people, more equity, or Aboriginal and Torres Strait Islander health, people can, in that marginalisation and that and that fear, because we're not having other conversations in those spaces, it makes it then difficult to talk about equity, because other people feel that they're missing out, and they are missing out, and that things aren't working as they should. People can't afford to buy their own, young people are not being in a position to buy their own home. There's a decreasing lack of affordable housing. Is Sydney going the way of London, and those kind of issues. And that's not just the poorest of the poor, how we used to try and understand it. It's happening a lot more across the gradient. So a bit what Liz talked about this morning, understanding that actually it affects us all. Usually the kind of richest 5% are okay, but it affects all people, and so that then affects the discussion, because actually people are fearful because they don't know how the system works, and they feel they're doing the right things. They've got an education, they've got a job, but somehow they can't get ahead. And there was a discussion, I think, in The Guardian about this, or there was a podcast with a range of people, one of whom is coming today, Cassandra Goldie, where we talked, they talked about the idea of fairness and this attachment that we have to Australia as you've got a chance for a fair go, and the same in the States, that, they were both countries where that was seen, but it's like the rules of the game have changed. So, and there's not much else in their place. And then you see people coming in, fleeing from other countries, and because you might be unemployed, you might have lost your job. If the other discourse around that is those people are coming, it's very difficult. And that doesn't mean, I think, one of the challenges with the Brexit was that people who wanted to leave were also being told, I read another piece where they were being told that they weren't educated, and that's not right either. That's not the issue. The issue is we need to be able to have a conversation about it where people feel they have to feel free to express their fear, but we have to have something that goes in place of that. So you can't come in and start talking about equity and fairness without recognising that people are going to be responding from, as we said, not only a values but an emotional point of view about whether they feel connected, whether they also feel disenfranchised from the system.
Absolutely. Thanks so much for that.
Sorry,
no, that's fantastic.